All right, good evening, everyone, and thank you for joining us tonight for our Woo You event with Dr. Stephanie Ramdass. The title of her presentation today is Rejuvenate Your Contact Lens Practice by Revisiting the Hybrid Modality. So I'm your host today, Dr. Ariel Sorenzi, and I'd like to introduce our speaker for tonight, Dr. Stephanie Ramdass. She cold started her practice in Ontario, Canada, and I have to say, because I practiced it in Mississauga. And in that practice, she focuses a lot on specialty lenses and things like myopia management. She graduated from the school in Puerto Rico, the optometry school in Puerto Rico, and completed a cornea and contact lens residency at MCO afterwards. You didn't put in here that you graduated valedictorian. You got to add that. That's amazing. So she is always contributing amazing articles to Contact Lens Spectrum. I've loved reading her articles, also in clinical and refractive optometry. And she is a committee member and contributing author to the International Myopia Institute and Canadian MIP Research Principal Investigator. So thank you so much for joining us tonight. We can't wait to hear your presentation.
Those are my financial disclosures. Thanks, everybody. Thanks, Dr. Sorenzi, for that wonderful introduction. And thank you for Woo You to inviting me for a speaker for tonight on the platform. Fantastic opportunity to kick off a three-part series discussing hybrid lenses. We're just going to rejuvenate your practice tonight and revisit a few concepts that maybe you already know, or perhaps you've heard that may cause limitations to scleral lens use. So we'll get right into the presentation. So we all know about the comfort of soft lenses. We know about the crisp optics that GP lenses can provide, both for our regular corneas and our irregular corneas. But what happens when we marry the two together? And so my interest with hybrid lenses really came from my residency year at the Michigan College of Optometry, which was a year where we spent fitting the lens on both the irregular and the regular cornea. A lot of that work came from clinical trials that were done on a series of regular patients who were new to hybrid lens wear. So there's a lot of interesting findings that I was able to pull out, and I hope to share some of those experiences with you guys today. So in preparation actually for today's presentation, I really wanted to gauge how my colleagues were fitting hybrid lenses and what they thought of the modality, how often they were using it. I asked a few colleagues in person, via text message, but I really got the biggest response when I put this call to action out in social media. And so I asked, using 5 words or less, describe your experiences with hybrid contact lenses. The next slide is busy, but we will be breaking this down. And there were quite a few responses from some fitters that I've known for some time, so they're quite seasoned in their experiences, and some that are students that I actually worked with at the University of Waterloo during labs. So quite a range of experiences that were presented, and we're going to break down based on some of these responses through the presentation today. So the first topic that I really want to tackle is design stability. So what we, and kind of one of the very, in the earliest type limitations and misconceptions associated with hybrid lenses were that they came apart in your eye. Some practitioners said that the fitting was inconsistent. Sometimes they're good, sometimes they're not. So let's dive in a little bit deeper as to where these responses may have come from. So I really wanted to look at the history of hybrid lenses. And so while the concept of piggybacking, where we use a GP lens, a gas permeable lens material, followed by a soft skirt fit underneath it, that's decades old. But the true concept of blending the GP material with a soft skirt really only came about in the 80s. The material was not the only limitation, but it was the biggest limitation because you had a lot of patients that couldn't wear the lens for a very long period of time. Very low decay materials, both for the center GP portion and for the soft skirt. There were some changes to the earlier iterations of the lens. You can see that there's an increase here for the decay of the lens material. That bond was still unstable, where you were having the two materials come apart. So it really wasn't until about 2001. So there's a little bit of a gap here, but the hybrid lens modality was resurrected in the early 2000s. And so you had improved materials, improved decay materials, a lot of oxygenation coming to the ocular surface. You could do more customizations to the lenses, but what really is kind of a key turning point, in addition to the newer materials, was that stable junction between the two material. We've even seen in more recent years further enhancements to the customization portion. We see some of the designs having a single base curve in the GP portion, and we'll talk a little bit through case examples how that impacts some of the fits. But you can see there's a continual increase to what we have available today in our modern day hybrid lenses, the highest decay materials for both the GP center and the soft skirt. So we really have the best opportunity to fit our corneas healthy with the materials available today. So this junction, let's just put this to rest right now, because this HyperBond that we have between the material in the center, the GP center, and the soft skirt, this was a poster that was presented in 2017, where they took 21 different samples and applied tensile strength that's equivalent to about 8.5 times of what we call digital pressure that you would normally apply during cleaning. And even with that amount of strength applied, you can see here, based on the image, that the tear that did occur when breakage did happen was not actually at the junction, but it was in the soft skirt itself. So that junction between the two materials is stable. We're just going to leave that one at that. When we talk about those original comments about the lenses being sometimes good, sometimes not, I think it really comes down to you as a fitter and understanding what in your toolbox works best for which patients. Not everything is going to work the same for all patients, and not everything's going to apply. I really feel like my best patients when it comes to the normal corneal population are those patients that have astigmatism where the sill is greater than the sphere, my oblique astigmats. Generally any astigmat truthfully that comes in, and I always ask them if they're established wearers, is there something that your lens isn't doing for you? And there are patients that I find will often say that their lens is like fluctuating vision, or I wish the vision could be clearer. I wish that I could see like how I do in my glasses. And so unless you probe for these comments, you won't necessarily get them. So really, I think for those types of patients, presbyopic patients, high prescriptions, there really is quite a range of patients that can work with these lenses. And through the cases that we'll present and talk through the day, I hope you'll see that, it's not just, let's say, that regular astigmatism patient that we might think of, or that irregular cornea that we might think of. Where that comment comes in of being sometimes good, sometimes not good, we have to really think about the irregular corneas that we're going to fit. In my personal practice, you're seeing this irregular cornea on the, let me see if I can minimize this here, on your top screen here. So this is a very well-defined ectasia. I do find more of my apical or slightly inferior to the pupil center. Those types of cones tend to work best with the hybrid lens design, the one specific for the irregular cornea. If you have a lot of irregularity in the inferior portion of the cornea, which can be assessed from topography or even from just knowing the case history of the patient, you may have a difficult time with centration of the lens on eye. And so those types of eyes might do better on a different lens modality. So it's really understanding the shape of your patient's eye, where their irregularity is, knowing that that GP center is usually a fixed size. and how much can you effectively vault over the surface of the eye in the case of the irregular cornea based on the irregularity that's present. So that's important to keep in mind when the lens is useful and when it's not. So when we talk about the second option that I received in comments, it's really coming down to tear flow, I find. So there were some practitioners that talked about the lens sealing off or there being suction. And that is a comment that I've heard from practitioners, not just in this platform where I asked the question. And so where really would we see this happen? The question, I think, can be solved easily that there is tear exchange. We know there's tear exchange. There was a study that was done in 2015 out of a research group at the Texas Eye Research and Technology Center, where they used a specific instrument that could measure the amount of decay of a high molecular weight fluorescein that was applied underneath the bowl of the lens. I just want to make a note here that high molecular fluorescein was used because it was necessary for the instrument, but it wasn't necessary for the fitting process. So this is on eyes that were fit that have established keratoconus. The eyes were fit according to manufacturer's recommendations, and then they looked to see how fast that high molecular weight fluorescein decayed over time. And what they found, that the tear exchange rate was about 2 to 3% per minute. And this actually is higher than some of the studies that look at tear exchange in scleral lenses. So there's definitely some sort of tear pump action. And in with the most modern day hybrid lenses that exist, there have been modifications to the skirt that allow for that tear pump action to be in effect and be more applicable and fit appropriately for each individual eye. So we'll talk about that a little bit later on. When it comes to that tear exchange, we know it's there, but are we still seeing neovascularization in these patients? And so when I talked about the historic hybrid lens designs, the ones that had the really low decay skirt, and then they would have that what we call seal off. So effectively, what does seal off mean? You would see the hybrid lens on eye, but you wouldn't see any movement. And so that, to me, with the low decay material is no different than a low decay overworn soft lens, right? So you're going to start to see that neovascularization into the cornea right at that limbus margin. So let's go through a case where I personally don't see this anymore, and I base it on careful evaluation of the lens on eye. With the high decay materials, I don't even consider it an issue. But here's an example of where we potentially needed to make a modification in order to avoid such an issue. So this is a case of a student who was fit at the Michigan College of Optometry. And this student he was established soft toric contact lens wearer. You can see his prescription. He's got a moderate amount of myopia and astigmatism, and he's not full limbus to limbus, but it's more than an apical amount of astigmatism, and his topographies are there. HVID was measured in order to evaluate this patient's eye size for the best fitting option. So let's evaluate the lens on eye. The lens was empirically manufactured, and so empirically ordered and then manufactured and sent to the office for this patient. So you can see a base curve is selected based on his topographies, his flat K. And then he's fit in a skirt. Based on his HVAD, he was fit in a medium skirt. So what are we evaluating here? The lens is on eye at dispense. It's moving. Ideally, you want it to move like a soft skirt, like a soft lens, excuse me. So here's the 1 week follow-up. And so if you guys are looking at the video, you can see that there isn't much movement there. Even upon push-up for this particular patient, I didn't notice any movement. Now, I've had cases before where there is no movement and the patient's doing okay. I remove the lens and I stain the eye and the cornea looks great. So be wary of the patients that say, I don't feel the lens at all in my eye. Those are the patients that you want them ideally to be extremely comfortable, but you have to make sure that you're really checking these eyes during your follow-up evaluations. So if you can really see, there's a little bubble stuck here in the soft skirt. And so with that bubble there, even when I do that push-up nudge, I can't get that to be released. And so this lens was really just too tight for the patient. And so when he's removing the lens, he removes it and the lens is fine. The cornea looks okay. But from a longevity standpoint, as this was just the 1 week follow-up, I chose to flatten his skirt so that he could wear it more on a healthy basis than I would be less concerned. So wears it for another few weeks and comes back, and then I will check him for a 1 month follow-up at that point. But he was fine with the flat skirt. That's what we finalized on. So some practitioners tend to feel that there is too much time required to fit it, and others feel that it's not difficult to fit at all, which I do feel like there's a certain amount of time invested that is needed to understand that these lenses do need a little bit more evaluation than what a soft lens would need, but you can actually fit it with no extra chair time required at all. Maybe just the time for you to explain and educate to the patient what the modality is. So I was a part of a roundtable discussion. This is GS, so the Global Specialty Lens Symposium, January of 2020. So this is right before COVID. I'm pretty sure a lot of us went home in that meeting and from that meeting and possibly had COVID, but who knows. And in that meeting, though, it was a roundtable discussion where we discussed the empirical fitting of hybrids. And at that time, there had been a new publication released, which was a joint effort by the American Academy of Optometry and the American Optometric Association. And so together, the two wanted to interpret and understand the new ISO standards for cleaning and making sure disinfection was good for multi-use lenses. So specifically for hybrids and lenses, what we want to focus on here, there was a very strict process that needed to be followed. So for example, I do webinars at the University of Waterloo. And so during those in-person or virtual workshops, we talk about this. And in the in-person, most of the schools and some of your practices as well have multi-use diagnostic sets, because historically that's how these lenses have been fit. And you should be disinfecting them following a very specific protocol, and then should be repeated every 28 days. Unless you have somebody dedicated to doing this, I know this won't necessarily be upheld in all practices. So they decided to just ditch the entire concept. Yes, if you have them, you should be cleaning them a certain way. But the whole goal is to fit them empirically right now, where all you really need, baseline refraction is what you would get from your regular eye exam. Topographies are great. Specifically axial topographies are great in order to get your keratometric readings. But if all you have, most instruments right now that have auto keratometry readings have some sort of topography-based views on them, but if not, you can still order based on those readings as well. Horizontal visible iris diameter is really important for fitting today because they are used to help customize your hybrid lens on eye. So it's really important that you measure it. You can measure it using instrumentation such as a topographer. You can use a HVID ruler. This is just a PD ruler, actually. And so what you see in the first image here, the ruler I have placed right underneath the eye in order to get, and it's actually a picture taken of the ruler, so then you can blow up the picture after. I mean, at the heart of COVID, you really didn't want to go right up to a patient and be measuring at that point. But in the second image, if you have the ruler really bisect the pupil, you get less of that kind of depth difference, and you can really go ahead and measure. So this would be the easiest way to get an HVID reading, and sometimes this might be your more accurate way based on topography. So, but if you don't have access to topography, you just need a ruler. When it comes to understanding pupil size and ocular dominance, there are some designs where they are pupil dependent, some are pupil independent, and if that's the case, you want to make sure you have these items measured. So those are a few of the extra items that you wouldn't necessarily have measured during a baseline exam, but they take seconds to measure. So I really don't see them being any longer in chair time. In fact, if you have a patient who is an astigmatic patient who's unhappy, arguably you'd be spending more time trying to troubleshoot their fit than if you kind of hammered it out with a hybrid lens. And then you can do a full custom-based hybrid. This is more for the irregular eye, where you can do topography-driven manufacturing. And then software can be used to design a lens for you, so you don't actually need to put any diagnostic lens on your eye. This question I found was, well, this comment actually. I don't really know how to gauge it as an experience, but I can tell you, after doing the workshop with students at the University of Waterloo, we had a lot of bubbles on the student population there. And so I wanted to discuss them because they had just come off their workshops with gas permeable lenses. And so to them, any bubble in the center meant the lens was too steep. And so with hybrids, it's a little bit different. And so in their minds, they're trying to marry what they've learned about GPs. How can we apply it to hybrids? So here's an example of a few different eyes where we looked at the lenses on eyes. You can see that there's 5 different examples. And so I just want to go through them really quickly. So this is probably no different, and I'm sure all you guys are really aware of what these are. These little bubbles tend to form, and these are an example of dimple veiling. Very common with brand new hybrid lenses when you put on eye, as the lens is trying to kind of nudge its way in. I generally sometimes apply a drop of artificial tear into the bowl of the lens, and that helps them go away upon the initial insertion. But otherwise, I just let them go. I don't make any changes, and I just watch. I'm looking to make sure that the lens is centered well on eye. And if I have my topographies correct, I don't need to put any fluorescein in. I can use my over refraction based on how the lens was fit off of their K ratings to understand if the lens is fit correctly. I'm not necessarily thinking this lens is steep. In option number 2 here, you can see that there's a bubble right at the junction between the gas perm and the soft skirt. That bubble typically is clinically insignificant at that time because, again, it's similar to when you take the lens out of the vial. Sometimes it's not perfectly aligned to the surface of the eye. The lens has to kind of nudge its way in. And so a patient may be a little bit more aware of this bubble, but as long as it's on the edge, we tend to leave it. So I historically have left it alone. I do make a change though if I see number 3, because number 3 is where you have almost like a full smile at the junction. And what that does is it tends to cause the lens to sink low. I'll talk a little bit later on about how centration of these lenses are really important. And so at that point, when you see that lens edge, sometimes you need to check your base curve. Steeping up your base curve can help to center that GP portion of it if your lens skirt is perfectly fine. So this is a question. If there is decentration, I make a change with this particular type of bubble. If it's centered really well and this type of bubble is alleviated by applying a drop of artificial tear, then I'm good to go. This is no different than that example I just showed you previously with that bubble that was stuck in the periphery of the skirt. So this is indicative of more of a tight fitting skirt. And I tend to flatten the skirt in these particular examples to make sure that I have a healthy fit, continual fit for this patient. And then example number 5 is a really overt bubble. So this is edge lift at the lens edge. This patient will be really aware of it. If you move the lid away, the patient will be a little more comfortable. And if not, and it doesn't alleviate just by kind of massaging the lens at that point, then you need to go ahead and tighten your skirt up. So next part to tackle is the fluorescein issue. So whether or not high molecular weight fluorescein is needed, there's no question about it. It's not needed at all anymore. Specifically with the high DK materials, they do not absorb into the skirt as they used to in the past. And with those ISO standards that I discussed, once they are disinfected through clear care, it actually cleans it off really well, just the regular fluorescein. But I do want to talk about a case where fluorescein is actually important, not high molecular weight, but regular fluorescein. So this is a case of a 26-year-old male who's been diagnosed with keratoconus, diagnosed at 21, who has a previous history of corneal GP wear. However, he frequently loses his lenses because they're unstable, and he wants to have a more comfortable lens option. So when we're looking at the diagnostic lens options for these patients, so this is potentially we have a diagnostic lens set in office. We look at the eye itself. We can see there is a very, like what I mentioned before, an apical amount of a very concentrated area of ectasia. I don't find that it's well dispersed. I don't find it's very inferior. This would give me a good indication where this patient wouldn't necessarily be needing to fit into a scleral lens modality, let's say. I think we can start with the hybrid lens modality. So here is an example where fluorescein, you definitely want to use it. Fluorescein is used in your evaluation. The lenses that are made for such an eye, like an irregular eye, does vault over. It's not based on flat K, they're based on vault. So how do we evaluate vault? We evaluate vault with fluorescein. Optic section is really important. These lenses tend to not, sometimes for scleral lens fitters out there, you want almost like a one-to-one relationship of your fluorescein to the thickness of your lens. With hybrid lenses, I find that it's more appropriate for it to be half the thickness of the actual lens thickness itself. The reason why you want to make sure you don't have too much thickness in your fluorescein pattern is because that increased amount of fluorescein can actually apply too much weight to this darkened area right here. This darkened area is a point of landing on the surface of the cornea. And if you have too much weight bearing in that area, the lens can tend to kind of settle down a little too much on the eye and can lead to lens seal off or lens erosion on the corneal surface. So fluorescein is definitely needed and important in these types of fits. When you have a patient, this is a regular corneal patient, there is a lens that has been removed from this eye. So I do, not alarming, you will, similar to like if you have an elastic band on your wrist, if you take a lens off, I always like to take a lens off during a follow-up visit and go ahead and stain the cornea with fluorescein. So this is either a regular cornea or an irregular cornea, whatever is the case. And so you're looking for areas of erosion or areas where there is concern where you need to make a fit change. And it's not uncommon to see an impression ring, but you're looking for true epithelial staining. Sometimes you might see pseudo staining because protein gets stagnant in the tear layer that's in there. So you really want to assess behind the microscope if it's true epithelial staining or not. So another good example of where fluorescein would be needed. Otherwise, you don't need it for your diagnostic or your empirical fits for the irregular. For the regular cornea, it's just for when you're trying to fit the irregular cornea where it needs to become more useful. And then on your follow-up visits, stain everybody. See what's going on underneath. You should be doing it for your regular evaluation anyways. For any type of contact lens modality, we talk about the lens wetting characteristics. Hybrids are no different, where there were some comments that were applied that had to do with deposits that were on the front surface. There were patients that some comments where they were better for patients that had, were active in sports, where they potentially would have to have the clearest vision, where they couldn't really afford to have dryness on the surface. And sometimes, though, these wetting characteristics can lead to the lens being harder to remove. So I just wanted to tackle some of these areas here. Here's an example of a patient who actually reported that their lens felt dry in the eye. If you can see a look in the video that the eye is drying up as in between blinks. The patient could be advised to blink a little faster for sure. But when it comes to hybrid lenses, you have like what troubleshooting options do we have? We can definitely apply a drop of preservative-free artificial tear. But if these are, active patients that are, whether they're athletes or whether they are just if they are going about their everyday, if they go to the gym, this necessarily does not want to be something that they have to tackle, and they want to have something that provides a little bit more moisture to the surface of the eye. So this is an example of a patient. These are non-invasive tear breakup measurements over the surface of the contact lens. And this is specifically a hybrid lens that has no surface coating. So with the modern day hybrid lenses, you have the ability to apply a surface coating on top of it. And so in this particular example, you can see there's a tear breakup time of less than 10 seconds. So this patient was already symptomatic to begin with. So I like to reserve the use of the surface coating for patients that have that dry eye. I don't necessarily like to start off with it for my fits, because then I don't have that troubleshooting ability thereafter. So you can see regarding, in this particular example, this patient was wearing a lens for a dispense visit. So this is without a lens on. This is with the lens on that doesn't have a coating. This is with the lens on that doesn't have a coating at the end of 1 week of wear. And so in this particular clinical trial, you can see that over time, there is still this decreased T-butt for this particular patient. For that same patient, though, when they are wearing the lens with the surface coating, again, on the left, this is their baseline measurement. Then the non-invasive tear breakup time is taken over top the lens with the coating at what we call the dispense visit. They wear the lens for a week, they come back for a week in this particular clinical trial, and they still retain that positive surface wetting. And so this particular patient was really happy with the lens design, knowing that they could alleviate some of the dryness symptoms that they were having. So again, it's knowing that the modification could be there for your lenses, but knowing when to use it. It's not necessarily something that you would use for every patient. There is a little bit of a caveat there, because I do find the surface coating makes it a little bit difficult for it to remove. Which goes right into our next section where we talk about care and handling. And so when we talk about, I wanted to repeat some of the comments there, because the hard to remove aspect of it makes it a little bit difficult for the ability for patients to get it off, but we'll talk about how you can troubleshoot that. The ability to use different solutions is important. Some solutions are not recommended with these lenses. Some practitioners felt that the lenses were a little bit pricier compared to others. And I just want to tackle the expensive part of it right off the bat, because when it comes to care and handling, I think important to include there is the replacement schedule. And when you think of the modality itself, it is recommended for a 6-month replacement schedule. I have some patients that replace quarterly if they're heavy depositors, or if they can't get 6 months out of their lens. I know that makes it a little bit more pricier. But for these patients, this is a custom lens design, and you're fitting it using a little bit more of a skill set. So they should be a little bit more expensive for patients, but if they work, I think they're the go-to modality for that particular patient that's in your chair. When it comes to the insertion part of it, it really is not that much different than inserting a soft lens. You want to make sure it's centered on the finger. Your eyes are held wide open. You want to put it right on the center as much as you possibly can. And so in this particular case, you can see the lens is going right onto the center. And that just helps that initial insertion experience, so the patient doesn't need to move the lens around too much. The removal part of it, so with the coating example that I said, in the care and handling portion of this presentation, this is where it gets a little bit trickier, because you have to make sure that you have a very narrow pinch. And so what I do like to recommend to patients is that they have their fingers super dry, and that dryness is, you're not just grabbing, because sometimes they'll grab just from the inferior portion of the soft skirt. You really want to grab from the soft skirt, but almost like your pads of your finger are feeling the edge of that GP. And that's how I find for myself, it's the easiest to remove that lens. And it seems to come off pretty easy. If they're still having difficulties with the lens removal, there are these useful tools that can be applied. There are finger cots that can aid with that grip. And also I have sent patients home with low lint tissue, or any tissue that works for the patient. where they're specifically using the piece of tissue to grab onto just the skirt to remove the lens itself. Some patients say it's counterintuitive. I'm asking them to make sure the fingers are really dry, but then I tell them to put the lenses, put a drop of lens of either artificial tear or saline in the eye. You want to make sure that they know that this is a possibility, because if they keep going too much against the conj surface, that conj can become slightly edematous and make it a little bit more difficult for the lens to remove. So that saline really does help with softening that lens on eye, but then making sure that the fingers are dry again in order to remove it. So that really, if you provide kind of instructions on care and handling and show that you have different options, in follow-up visits, I often ask patients, how was it over the week or the month of you wearing? Did you find that you were getting improved technique over time? And so if they're having difficulties, we just go through a quick little mini teach so they can understand what they're potentially doing wrong. When it comes to the solutions that are required for the particular hybrid lenses, it really just depends on if you're fitting the regular cornea or the irregular cornea. There are certain multi-purpose solutions that are preferred over others. So you definitely want to ask your manufacturer as to which one is more appropriate. Certain ones, there are certain in-house studies that can be done that show they're not compatible with certain materials. So that's a given for across any lens modality that you use. Peroxide-based systems are my go-to. I like to use them. There have been some comments where you'd have almost like a little bit of like a chalky deposit on the posterior portion, almost right at the junction of where the lens is. If that is the case, double check your patient is actually removing the lenses as they should be, because sometimes a lot of these problems, like whether it's the neo or the seal-off or these chalky deposits, a lot of the times that, I haven't seen it in my clinical experiences, and I've experienced quite a bit of hybrids, but it's from overwear in some cases where I've heard of. And so if a patient doesn't come back for follow-ups, the patient's wearing it, for a year at a time, that's not how the lens should be used. And those are reasons why you'll have some issues tend to come up. When it comes to the insertion portion of it, using preservative-free saline or preservative-free artificial tears are important if you're using for that hybrid lens type that's vaulting over the surface of the eye. And otherwise, re-wetting drops that are, if the patient, for example, does not have a certain coating that's helping with dryness, there are certain re-wetting drops. Ultimately, I like to go for preservative-free tears that can help improve the comfort of the lens on eye. So there's a range of solutions for care and handling. It is important to understand them, and the best thing to do is to check with the manufacturer what's recommended. So I want to spend a little bit more time in this section because there is a patient experience that I have, at least two now, where patients come in and say that, why can't I just have vision like my glasses? And I really find that we all know as contact lens fitters and wearers ourselves, that sometimes we have that superior vision in our contact lenses. If it's a certain modality, maybe we don't get it with soft. And so, these lenses tend to center very well on eye. That was the whole purpose of marrying the two materials together, to get that GP to center on those irregular and regular corneas. But let's go through a couple of cases where the vision really is as good as the glasses. So here's an example of two different eyes. You can see that these are taken at the same magnification. There is a smaller HVID on the left side, a larger HVID on the right. And so with this particular case, I'm just going to highlight where the hybrid lens is. And what really is important when it comes to fitting these lenses to get the vision like the glasses is centration. If the lenses are not centered up properly, if that GP is not the appropriate base curve for that eye, if the soft skirt's not the appropriate skirt for that particular patient, you will go ahead and induce SIL on a decentered lens. The lens might kind of get stuck in place. It might not move. The patient might say, I don't feel it. The comfort's great. Maybe they'll have, semi-good vision, maybe it'll be great vision, but that induced SIL is not appropriate sometimes for some patients, and they may start to complain of glare and halo. So if you took the lens off, you might see a kind of decentered impression ring on the surface of the eye. So really try to modify your lens to get the lens centered as best as you can to obtain the vision like the glasses. So here are two separate sisters. You can see both of them, similar to that very earlier case that we talked about. You have high amount of, or moderate amount of myopia with astigmatism. K's are pretty, they are a little bit steeper in both cases, but for the most part, they are corresponding to the refractive SIL. You can see that their HVADs are pretty large. So I can tell you that these girls have tried all types of contact lenses because they're my nieces. And so they have really wanted to wear dailies. There's no daily modality that I can get on their eye that is centered and that is clear for them. Vision fluctuates and these girls aren't very happy. And they have 16-year-old just got her license actually, and just really notices that her vision is not clear, especially at night. And so here's the first dispense of a lens on that 16-year-old. So ideally, you can see that the GP portion of the lens, which is right here, sometimes you got to be careful if you're looking from behind the slit lamp, you don't have the GP portion perfectly centered on eye. The shadow can kind of veer you off and make you feel like you have decentration. But this is at the initial dispense, well-centered lens on eye. At the 1 week follow-up for this particular patient, you can see that there is a little bit of decentration, but as the patient is blinking and we do the push-up test, there is still some movement. I didn't really see as much movement until I initiated the push-up. And so that is something that you want to, again, you'll take off, you'll evaluate this patient's cornea and make sure everything looks okay. But to date, this is the best modality for her because she actually feels her vision's pretty good. It's the best that she's been able to obtain so far. This is another one of my challenging cases because this patient, and I don't know why I didn't go to hybrids to begin with, but anyways, let me take you down his journey. So 58-year-old male, history of LASIK about 7 years ago. You can see from the topographies where he had his treatment area. And he notices a blur at night when driving. He carries around 58, but he has +3 readers because he just loves to read. He goes to thrift stores to look for certain classic books. But ultimately, he wants better vision. He does notice that distance vision is a little blurry, and obviously he's battling his own presbyopic woes. And so occupation, he does have a high demand for screen time. And so what did we need? So I took these baseline measurements, but I did not order hybrids to begin with. So what I did was, so HVAD in this case, I did use the topography to measure, but again, you don't need a topography to measure HVAD. Whatever you use, just report. HVAD we know is truthfully looking at it this way, and with DVID, sometimes it's unrepresentative of what the true HVAD is. So you have to sometimes add a few millimeters in order to get a true response, but report your visible iris diameter measurements to your consultation team who is manufacturing your lens. So what did we do? I tried simultaneous design soft lenses to begin with. I tried a reverse geometry, front surface, center near design, GP. I tried a translating GP. And I also tried an aspheric lid attach. So when you pull starter practice, you can do whatever you want. So he was kind of my guinea pig, and I really wanted to try different designs with him and see what worked. Ultimately, it didn't matter if I tried to tuck a lens under that upper lid or if I tried to have that lens sit against the inferior portion of the lid itself. He wasn't happy. He wasn't happy with the quality of vision. One time he left and he seemed like he was okay in office. And then he went to go make a left turn and he's like, I thought I was going to get into an accident. So he wasn't happy. And so he was about to give up on the entire process, but we ended up fitting a modality, the newest modality for hybrid lens when it comes to multifocal lens wearers, where you can have extended depth of focus technology that has been applied to the front surface of the lens. So you can have the optics, the GP, as well as the near optics applied to the center. So it was a different design completely from all the other designs tried. And these are the lenses on his eye. So lenses were dispensed. If you can see there are those dimple veiling bubbles that we referred to. He instantaneously, he's like, I can see. He looked at his watch because that was his first thing that he would do. Distance vision was great. He was happy, and so I let him go. And he came back at the follow-up visit. This is the right eye. You can see there's still movement of the lens on eye. He's got a little bit of a conjunctival growth there. The lens is still sitting over that area, and he was happy. And so, I mean, I asked myself, why didn't I try that modality to begin with? I think like the contact lens fitter in me really wanted to know why others didn't work. But yeah, great example. He is a post-LASIK patient. You do have to fit these lenses. There is a high enough DK in the GP center, but you need to make sure that there is enough of a fitting modality and application applied to the particular lens based on the case. And that's something you can discuss with the consultation team in order to adequately fit your patients. Not every case is going to work with these particular design, but I do find for my patients that need multifocal optics, it's a great option. So I want to end off the presentation today with addressing comfort. You know, going back to those students at the University of Waterloo, because they really they give you the most honest responses. And so their first thing, especially with them just coming off of their gas perm lectures, was like, oh, this is not as bad as a gas perm lens. And so ultimately, yes, you're going to feel the lenses on eye. They're not soft lenses. Soft lenses are like saran wrap. The saran wrap is going to feel like there's nothing on the surface of the eye. But the GP portion, you're aiming to have this kind of leeway between how comfortable they are and how great the vision could be. And so when you're looking at comfort, it's really important. So this was through a clinical trial of the lenses on eyes. We really looked at a series of wearers, and these wearers had never worn, some had never worn contact lenses before, some had worn, but not hybrids. They were all new to hybrid lens wear. And you basically, I like to say, you only know what you know. So if you know contact lenses in eye that are soft and they're comfortable, then that's what you expect them to be. So you have to educate that you're going to feel these a little bit on your eye. But what we found was that there was this adaptation period. We gave the subjects that were in this clinical trial daily surveys, and these surveys they took and they reported in the morning, in the around noon, and in the evening how their level of comfort was. And what we found when we plotted these charts were that comfort improved over time. It took about a week. There was an adaptation period, but these patients tend to become more comfortable, not with just insertion and removal, but with general comfort of the lens on eye. So that's just what you have to educate patients so they can understand that I'm not going to necessarily be completely comfortable to start off with. And if you really educate on the insertion and removal part, you can help them become a little bit more successful with their contact lens modality for sure. Getting it centered on eye is really important because, like I said, the more centered you are and the less you move it around, the less irritation to the corneal surface for that extended wear time that you have thereafter. So the attitude of the practitioner, I mean, I just gave you a whole bunch of comments. Some were positive, some were not so positive. And if you are, you're in the driver's seat and you know that you want to do best for your patient, and you understand that there are certain nuances of the design that make them fantastic, and there are certain ones that need to be really evaluated to make sure that they're fitting properly, then it's really up to you to kind of drive home the success of the lens itself. I don't find that, like I said at the very beginning, they're sometimes good, they're sometimes bad, in the sense they're not for every single patient that's going to come through your chair, but understanding who is best suited for these lenses really will help you be successful in your practice in determining which patient would be best fit with them. In the case of the surface wetting, I talked about applying that coating. And so from this clinical trial of regular patients, where we learned about the adaptation over time, using a drop of artificial tear is very important in those patients that do feel dryness is occurring, or you can apply that surface coating in order for these patients to feel more comfortable. So don't forget to bring them back for their follow-up visit. Don't forget to have them, educate along the way if there's anything additional you want to ask. And if they're motivated for improved vision and you're excited about them having improved vision, a lot of that, it stems to their level of success and whether or not they're going to order their annual supply and then thereafter. So those are kind of my takes at hybrid lenses in rejuvenating it in your practice. Maybe there's a few things that you took away that you already knew. Maybe there were some misconceptions that we addressed today, but it is an excellent tool to apply into your practice. And I'll take any questions that we have right now.